Dr. James Harrison had performed over 4,000 open heart surgeries in his career. He had held beating hearts in his gloved hands. He had sewn arteries back together that looked like they had been attacked from the inside. He had stood over operating tables at 2 a.m, trying to save people who had no idea, absolutely no idea, what had brought them to that table in the first place. And after 4 decades of cardiac surgery, he noticed a pattern that haunted him. The patients who came to him with the most severely damaged hearts, the most inflamed arteries, the most dangerous and unpredictable cardiac tissue, they were not the ones who had smoked for 40 years. They were not the heavy drinkers. They were not the people who had eaten cheeseburgers every day of their lives. They were the careful ones, the responsible ones, the seniors who followed their doctor's instructions, took their medications faithfully, read health articles, and genuinely believed they were doing everything right. And again, when he reviewed their medication lists before surgery, he found the same drug sitting there quietly on the list. A drug prescribed to millions of Americans over 60. A drug that most doctors hand out like candy at annual checkups. A drug that almost every senior in America either takes themselves or knows someone who takes daily. A drug that, according to mounting scientific evidence, is doing things to the aging heart that most patients are never warned about. By the time you finish reading this, you will know exactly which drug cardiac surgeons are increasingly concerned about, what it does to the heart of a person over 60, why your doctor may not have warned you, and what you can do right now to protect your heart before it is too late. What cardiac surgeons see that regular doctors miss, there is a fundamental difference between what a cardiologist sees and what a cardiac surgeon sees. Your cardiologist sees you in an office, they review your numbers, check your blood pressure, look at your EKG, and make decisions based on data on a screen. That is important and valuable work, but it is work done at a distance from the actual physical reality of what is happening inside your chest. A cardiac surgeon sees something entirely different. A cardiac surgeon sees the heart itself. They see the arteries up close, under surgical lights, with their own eyes and hands. They see the texture of the tissue, the color of the fat surrounding the heart, the condition of the vessel walls, the degree of inflammation, the stiffness of structures that should be flexible and alive. And what cardiac surgeons have been observing and discussing among themselves for years, in surgical lounges, at conferences, in the medical literature, is a pattern that is deeply alarming and almost completely unknown to the general public. The hearts and arteries of American seniors who have been on certain long-term medications look fundamentally different from hearts that have not been exposed to those medications. Older, more inflamed, more calcified, more vulnerable. Even in patients whose standard cardiac tests, their cholesterol numbers, their EKGs, their stress tests had come back completely normal just months before they ended up on the operating table. To understand what drug is at the center of this growing concern, you first need to understand something critical about how the aging heart works and why it is so uniquely vulnerable to certain chemical interventions. After the age of 60, the human heart undergoes a series of profound changes that have nothing to do with disease and everything to do with the natural process of aging. The heart muscle itself becomes slightly stiffer and less elastic. The electrical conduction system that coordinates the heartbeat becomes less precise. The coronary arteries, the blood vessels that feed oxygen directly to the heart muscle, become less flexible and more prone to inflammation. The mitochondria inside heart muscle cells, which produce the energy that powers every single heartbeat, become less efficient and more vulnerable to disruption. These changes are normal. They happen to everyone. And for most people, a healthy lifestyle, reasonable medications, and good luck mean these changes proceed slowly and manageably over decades without causing catastrophic problems. But here is the critical vulnerability that most people over 60 are never warned about. The aging heart is extraordinarily sensitive to anything that interferes with its energy production system. The mitochondria inside heart muscle cells in a 65-year-old are already working harder with less efficiency than they were at 35. They have much less reserve. They are much less tolerant of substances that disrupt their function. And when those mitochondria are impaired, when their energy output drops even slightly, the heart muscle weakens, the electrical system becomes unstable, and the risk of serious cardiac events increases dramatically. Now we can talk about the drug that cardiac surgeons are increasingly concerned about. The drug that appears again and again on the medication lists of patients with severely damaged hearts is a class of cholesterol-lowering medications called statins. You know them by their brand names: Lipitor, Crestor, Zocor, Pravachol, Simvastatin. They are among the most widely prescribed medications in the entire history of medicine. Approximately 40 million Americans take a statin drug every single day. Among Americans over 60, the prescription rate is staggering. In some age groups, more than half of all adults are on a statin. Now, before you stop reading or dismiss what comes next, this is not an anti-medicine article. Statins have genuine, well-documented benefits for specific populations, particularly for people who have already had a heart attack or stroke and are at very high risk of another one. That evidence is real and should not be dismissed. But here is what the evidence also shows. Evidence that receives far less attention and is almost never discussed openly with patients. Statins work by blocking an enzyme called HMG-CoA reductase, which the liver uses to produce cholesterol. This successfully lowers LDL cholesterol levels in the blood. But that same enzyme pathway is also responsible for producing a molecule called coenzyme Q10, CoQ10. CoQ10 is not a minor biochemical detail. CoQ10 is the essential fuel that powers the mitochondria in every cell in your body. And nowhere in the body are mitochondria more critical, more active, or more numerous than in the heart muscle. The heart never stops beating. It requires a continuous, uninterrupted supply of CoQ10 to maintain the energy output that keeps it beating 100,000 times every single day. When statins block the enzyme pathway that produces cholesterol, they simultaneously and unavoidably block the production of CoQ10. The research on this is not controversial. It is well established in the medical literature. Statin therapy reduces blood levels of CoQ10 by between 40 and 50% in most patients, sometimes significantly more. For a 35-year-old with abundant mitochondrial reserves, that reduction is manageable. The system has enough redundancy to compensate. For a 65-year-old whose heart mitochondria are already aging, already less efficient, already operating with reduced reserve, losing 40 to 50% of their CoQ10 production is not a minor inconvenience. It is a direct hit to the energy system of an organ that cannot afford to lose energy, ever. This is what cardiac surgeons see on the operating table. Hearts that are energy-starved, muscle tissue that is weaker and less resilient than it should be. A pattern that correlates with disturbing consistency with long-term statin use in older patients. The evidence your doctor has never shown you, and the side effects millions of seniors are told to ignore. The CoQ10 depletion mechanism is not a fringe theory promoted by supplement companies. It is mainstream biochemistry that has been known to the medical community for decades. In fact, the original patent application for lovastatin, one of the first statin drugs, filed by Merck in the 1980s, included a provision for combining the statin with CoQ10 supplementation specifically to prevent the cardiac damage that CoQ10 depletion might cause. Read that again carefully. The drug company that invented statins knew from the very beginning that these drugs depleted CoQ10. They knew it was a potential cardiac risk. They included a supplementation provision in their own patent. And then, for reasons that involve market economics more than patient welfare, that combination was never developed into standard practice. Statins went to market alone. Patients were not routinely warned about CoQ10 depletion, and the drug became one of the most profitable medications in pharmaceutical history. But the scientific evidence has continued to accumulate over the decades since. A study published in the journal Biofactors found that CoQ10 supplementation in statin-treated patients significantly improved measures of heart function and reduced markers of cardiac oxidative stress. Research published in the American Journal of Cardiology found associations between statin-induced CoQ10 depletion and increased rates of heart failure in certain patient populations. Multiple studies have found that patients with the most severe forms of statin side effects, including the muscle damage condition called rhabdomyolysis, show the most dramatic CoQ10 depletion. And here is perhaps the most clinically significant finding of all for older Americans. A landmark study examining heart failure patients found that those treated with CoQ10 supplementation had significantly better outcomes, including lower rates of major cardiac events and lower mortality than those who were not supplemented. The researchers concluded that CoQ10 deficiency may be a significant contributing factor to the progression of heart failure in older adults. And the most common cause of CoQ10 deficiency in the modern American patient over 60 is statin therapy. But CoQ10 depletion is not the only mechanism through which statins may harm the aging heart. There is a second, equally important pathway that receives almost no attention in standard medical discussions with patients. Statins cause muscle damage. This is one of the most well-documented and commonly reported side effects of statin therapy. The medical term is statin myopathy, and it ranges from mild muscle aches and weakness, which up to 30% of statin users experience, to severe muscle breakdown that can be life-threatening. Here is the detail that most people over 60 are never told. The heart is a muscle. It is the most important muscle in your body. And when statins cause muscle damage throughout the body, that damage does not spare the heart muscle. Research has demonstrated that statin-induced muscle cell damage occurs in cardiac tissue as well as in skeletal muscle. And in the aging heart, which already has reduced capacity for repair and regeneration, that damage accumulates over time. Many patients who complain of statin-related muscle pain are told by their doctors that the benefits outweigh the side effects and to continue taking the medication. Some patients are told that their muscle pain is not real or is psychosomatic. Some are simply told to exercise more, as though exercise will solve a drug-induced biochemical disruption. And they continue taking the statin while the damage quietly accumulates in muscles throughout their body, including the one muscle they absolutely cannot afford to lose. The third mechanism involves inflammation, specifically a paradox that has confused researchers for years. Statins have well-documented anti-inflammatory properties, which is one of the reasons they are believed to reduce heart attack risk beyond their cholesterol-lowering effects. But in a subset of patients, a subset that appears to be disproportionately represented among older adults on long-term therapy, statins can actually trigger a condition called statin-induced autoimmune myopathy, in which the immune system begins attacking muscle tissue in response to the drug. This is not the mild muscle ache that many statin users experience. This is an active inflammatory process that can cause severe muscle damage, elevated cardiac enzymes, and in some cases, serious and lasting heart dysfunction. Now here is the question you are probably asking yourself at this point. If all of this evidence exists, if cardiac surgeons are seeing these patterns on the operating table, if the research literature contains all of this data, why is your doctor not telling you about it? Why are statins still prescribed to tens of millions of seniors without routine CoQ10 supplementation? Why are patients not warned? The honest answer involves several uncomfortable realities about how medicine works in America. Doctors are extraordinarily busy. Most appointments are 15 minutes long. Statins have strong support from major cardiology guidelines, which are updated slowly and conservatively. The pharmaceutical industry has invested billions of dollars in promoting statin therapy, and that investment has shaped medical education, continuing education for doctors, and the guidelines that doctors follow. And most fundamentally, the benefits of statins for high-risk patients are real and well documented, which makes it very difficult for individual physicians to engage critically with the more nuanced and contested question of whether those same drugs might be causing serious harm in lower-risk older patients, taking them primarily for prevention. This is not a conspiracy. It is the ordinary, predictable result of a medical system that is better at treating acute problems than at carefully weighing the long-term risks of chronic medication use in an aging population. But you deserve to know the full picture. And in part 3, we are going to talk about exactly what you can do. Practical, specific, evidence-based steps to protect your heart right now. How to protect your heart, what to ask your doctor, and what to do today. Everything you have learned in the first 2 parts of this story leads to one essential and empowering conclusion. You are not powerless. You are not at the mercy of a medication list that nobody has ever fully explained to you. You have options, you have the right to ask hard questions, and there are specific evidence-based actions you can take today to protect your heart. Let's go through them clearly and without unnecessary complexity. The first and most important step is to have an honest, informed conversation with your doctor about why you are taking a statin. Not just that you are taking one, but specifically what the medical justification is for your individual situation. This matters enormously because statins are not equally beneficial for all patients. The evidence for statin benefit is strongest for people who have already had a cardiovascular event, a heart attack, a stroke, a coronary intervention, and are at high risk of a second one. For these patients, the benefits are real, documented, and likely outweigh the risks for most individuals. But statins are also routinely prescribed to millions of older Americans for what is called primary prevention, meaning they have never had a cardiovascular event, and the medication is being given to try to prevent a first one. The evidence for statin benefit in primary prevention, particularly in adults over 75 who do not have diabetes or established heart disease, is significantly weaker than most patients are told. Several major research reviews have found that in older adults without prior cardiovascular events, statins may provide little to no mortality benefit while still carrying the full risk of side effects. Ask your doctor directly. Am I taking this statin because I have already had a cardiac event, or is this for primary prevention? And given my age and overall health situation, does the current evidence support me continuing this medication? That single conversation could change your treatment plan in ways that significantly benefit your heart health. The second step is to ask your doctor about CoQ10 supplementation if you're going to continue statin therapy. The evidence supporting CoQ10 supplementation in statin-treated patients, particularly older adults, is substantial enough that many cardiologists already recommend it routinely. A typical supplemental dose studied in clinical research ranges from 100 to 300 milligrams per day of ubiquinol, the reduced, more bioavailable form of CoQ10. Do not simply buy the cheapest CoQ10 supplement at the pharmacy without discussing it with your doctor first, as CoQ10 can interact with certain blood thinners. But do have this conversation. If your doctor is unfamiliar with the CoQ10 depletion research, that itself is important information, it may be time to seek a consultation with a cardiologist who is more current on the cardiac aging literature. The third step is to track and report muscle symptoms with absolute seriousness and specificity. Many statin users experience muscle aches, weakness, fatigue, or difficulty with physical activities, and attribute these symptoms to aging rather than to their medication. This is a critical and potentially dangerous mistake. If you are taking a statin and you experience new or worsening muscle pain, unusual weakness, fatigue that feels different from normal tiredness, or dark-colored urine, which can indicate muscle breakdown products being filtered by the kidneys, report these symptoms to your doctor immediately and ask for a blood test measuring creatine kinase levels. Elevated creatine kinase is a direct marker of muscle damage. And if your doctor dismisses your muscle symptoms without testing, push back firmly. You have the right to have your symptoms investigated. The fourth step is to understand and actively reduce the other factors that increase the cardiac risk associated with statin use in older adults. Statin-related muscle and cardiac damage is significantly worsened by certain drug interactions. Grapefruit and grapefruit juice interact with many statins, particularly simvastatin and lovastatin, and dramatically increase the concentration of the drug in your bloodstream, intensifying all of its effects, including the damaging ones. If you take a statin, avoid grapefruit entirely. Several other medications also interact with statins to increase muscle damage risk, including certain antibiotics, antifungal medications, and some heart medications. Review your complete medication list with your doctor or pharmacist specifically for statin interactions. This is not something that happens automatically in most medical practices. You need to ask for it. The fifth step is to aggressively support your heart's energy system through the lifestyle factors that are fully within your control and that have the most powerful evidence behind them. Regular moderate exercise, even walking 30 minutes 5 days a week, improves mitochondrial function in heart muscle cells, increases CoQ10 production, reduces inflammation, and strengthens the heart in ways that no medication can replicate. Reducing refined sugar and processed foods lowers the chronic inflammation that damages coronary arteries. Prioritizing sleep, 7 to 8 hours of quality sleep per night, allows the heart and its energy systems to repair and regenerate. Managing chronic stress through whatever practice works for you, meditation, prayer, time in nature, social connection, directly reduces the inflammatory hormones that accelerate cardiac aging. These are not vague wellness recommendations. They are evidence-based cardiac protective interventions that work at the same biological level as the drug mechanisms we have been discussing throughout this story. The sixth step is to get a comprehensive cardiac evaluation that goes beyond standard cholesterol numbers. A coronary calcium scan, a low-radiation CT scan that directly measures calcium deposits in the coronary arteries, gives a much more accurate picture of actual arterial disease than a cholesterol panel alone. An advanced lipid panel that measures particle size and number rather than just total LDL cholesterol provides significantly more clinically useful information for cardiac risk assessment. An inflammatory marker called high-sensitivity CRP provides direct evidence of the arterial inflammation that drives heart attacks independently of cholesterol levels. These tests are not routinely ordered at most annual physicals. But they are available, they are not prohibitively expensive, and for someone over 60 who wants a genuinely complete picture of their cardiac health, they are worth asking about. The seventh step is this. If you are over 60, if you are taking a statin, and if you have experienced any of the symptoms or risk factors we have discussed, talk to your doctor this week, not next month, not at your next scheduled annual physical 6 months from now. This week, the pattern that cardiac surgeons see on the operating table does not develop overnight. It develops over years of silent, invisible damage. But the time to interrupt that pattern is before you are on the operating table, not after. Dr. Harrison retired from surgery several years ago, but he never stopped talking about what he had seen over 4 decades in the operating room. In the years since his retirement, he has given lectures, written papers, and spoken to anyone who would listen about the pattern he observed. The correlation between long-term statin use without CoQ10 support, the aging heart's energy crisis, and the damage he witnessed firsthand in thousands of cardiac patients who had followed their doctor's instructions faithfully and still ended up on his table. His message was never that statins are evil. His message was always the same simple truth. Every powerful drug has powerful effects on both sides of the ledger. The benefits of statins for high-risk patients are real. The risks for aging hearts, particularly the CoQ10 depletion, the muscle damage, and the mitochondrial energy crisis, are equally real. Both deserve to be part of the conversation between every doctor and every patient over 60 who is being asked to take these medications for the rest of their life. You now have that conversation. You now have the knowledge that most people sitting in their cardiologist's waiting room do not have. Use it. Ask the questions. Protect your heart. Because nobody, not your doctor, not your cardiologist, and certainly not the pharmaceutical company whose drug you are taking, is going to protect it for you.